Thank you very much. I am deeply honored to be part of this distinguished symposium, and particularly to have the opportunity to discuss a lecture of Uwe's, from whom I have learned so much of what economists and health policymakers know about healthcare comes from Uwe's writings. And as I was thinking about it on my way into the lecture, I realized that Uwe's stature and position in the world of health policy actually reminds me of my 10-year-old son's favorite television show. I don't know whether you get this station here in Michigan, but his favorite show is a show called MYTHBUSTERS. Do you know this show? Where they take some popular belief about something and they really test it out. So I actually, I'm going to redo this. This is, Uwe is the premier myth buster, I think, of American health policy, telling us which of the many things that we firmly believe is really not true. So in my discussion today, I'm going to put on the hat of a health policy wonk. I actually started, this is somewhat uncharted territory for me. I'm going to talk about ethics and politics. I actually started out with some economics, but it was at 6:30 this morning that I took the last two economic slides out of this talk. And so now I am left only with ethics and policy, and we'll see if I can fake it. But I want to start off by talking about health system design and reiterating a point that Uwe made yesterday, which is really that we have to design a system with values in mind. We have to be thinking about what it is we are trying to achieve before we can go through the exercise of figuring out the best way to achieve it. That is, ethics are really quite central in a certain respect to health policy design. But what is it we seek to do could have many dimensions, and I think it's important to realize that the values, the policy is motivated by goals. Those goals are not always social policy goals. I'm reminded that the Gingrich successful effort to derail the Clinton health plan was not motivated so much by ideology, but by the belief, that I'll come back to later, that if the Democrats were able to pass universal health insurance, they would secure their position in political power. So it was as much ideology in the service of politics as politics in the service of ideology. So yesterday we talked in the discussion a little bit about why one might want to make change in why might want to move towards healthcare reform and universal health insurance. And I think the first answer that comes to most people's minds when we think about why we want to do health insurance reform is because we want to use health insurance as a vehicle to improve people's health. And there was a question yesterday at the end of the discussion on this point. It was raised yesterday. I've always been skeptical about this argument for the reason that the notion of redistributing health, of trying to get people access to medical care, long predates the value of medical care itself. The Hippocratic Oath comes from a time when doctors could do nothing for you. And nonetheless, we felt it was important that people have access to them. So the reason we want people to have access to physicians cannot be simply an instrumental function of what it does for one's health. I actually think that the idea that capabilities, that it's because of what we are going to do with the products of medical care that it is important, is probably not the right way to frame this argument. It is true, and Catherine McLaughlin is in the audience somewhere, that we know now that there's a substantial literature showing that health insurance improves health. The last two studies that I looked on at this suggest that it makes about a 10% difference in mortality each year. But what does that actually translate into if you actually look at life expectancy of an uninsured person who gets Medicare at 65 compared to an insured person who gets Medicare at 65? I didn't spell this right. The life expectancy difference is only 6 months. Even the quality-adjusted life expectancy difference is only about 10 months. And to contrast that, if you think about smoking, the life expectancy difference between a smoker and a non-smoker is somewhere around 6 to 10 years, and uninsured people are twice as likely to smoke as insured people are. If what we were really concerned about here is improving the health of uninsured people, what we ought to do is just raise taxes on cigarettes and not bother with health care reform. It would get us the same distance in terms of improving people's health. So I don't think that is the value that centrally motivates the move to health care reform. A second point that Uwe suggested yesterday is that the reason to do this is to provide uninsured people with financial protection. Again, I don't think this squares so well with the history of where healthcare access and so on comes from, but there is a growing literature on healthcare and bankruptcy. Actually, Teresa Sullivan, your provost, is a central author on this, and you look at what happens, what is the relationship between health and bankruptcy. You find that people who've had health events are actually much more likely to have bankruptcies, and that medical bills very typically include are very typically included in bankruptcy filings. But it is ill health and not the absence or presence of health insurance that is the factor that determines whether people have medical bills in their bankruptcy filing. Those who had insurance and those who did not were about equally likely to report medical bills. And in fact, if you look at the cost estimates for various proposals for healthcare reform, most of them would actually impose a larger financial burden on many of the uninsured than they currently face. The reason for that is that they would probably lead people to use more healthcare services, therefore to pay co-payments on those additional healthcare services. It's actually not the case, depending on how you design the thing, that you will actually reduce financial obligations for uninsured people. So if it isn't because health insurance does either of those things for you, why should we care? And I have to say that my career has been centrally devoted to the idea that we need to expand health insurance to the uninsured. Why should I care about this if I don't think it's about health or about financial protection? And I think, and I hope that since this is a philosophy lecture, somebody here will tell me what philosophy I'm actually espousing here, because I believe there must be one. But it seems to me that the value of health insurance is inherent and not instrumental. That is, what health insurance allows you to do is that when you are in a position of pain or suffering, or someone in your family is in a position of pain or suffering, you essentially have an entitlement to seek services to get out of that uncomfortable position. For whatever reason, whether it's a fault of your own or not, you're in pain. You should not have to feel obliged to others, to call on the kindness of strangers, to request other people to be compassionate and generous to you in your hour of greatest need. You ought not, your decisions about your life ought not to be left to the capriciousness of unaccountable healthcare providers who might or might not decide that now is the time that you need services. And yet, that is very much the case for an uninsured person in the United States today. I didn't put it on here because I wasn't sure whether the audio would work, but the state of Maryland ran a video series on faces of the uninsured, and I've shown them to my classes to try to see what is it that really compels people in these stories. And I think the one that people almost burst into tears about is a man in his 40s, a truck driver who's injured, and he talks about his experience, how he was uninsured, he lost his business, and so on. He said, but you know, the worst thing was, what they took away from me was my dignity as a human being. Having to go and ask people to care for me, to beg people after I had been self-reliant all my life, it took away my dignity as a human being. And I think that if we think of this as an individual value, that we are all entitled to the dignity of being entitled to services when we are in pain and suffering, that is perhaps the most clear reason, even though a much more difficult one to explain politically, than anything else for why we need to expand health insurance coverage. Now, the response to this inherent need of human beings for care when they are in pain, and that is the response that goes back to how do you pronounce it? Hippocrates? Back in all of our religious traditions, has been responded to in other developed countries by giving people a public entitlement to receiving those healthcare services. Professionals in those countries answer to government authority. They are not able to capriciously decide whether somebody is in need of care or not. And it is not from benevolence that we expect people to be treated. In fact, and here's my quote from an economist in a very different context, Adam Smith was actually very skeptical of the importance of benevolence as a central organizing feature of human institutions. He argued that the market was a better alternative. What we have in this country, I think, is that we rely on benevolence but we rely on benevolence in the guise of a market. We don't actually, we don't use the market so much, but we actually rely on benevolence to try and get care to people in need. So the U.S. response, I think, as a response of reliance on professional compassion, and it contains within it a set of very important values. So I think it is not a question of Americans not having values, but of having somewhat distinctive values. I was really struck by this once when I met a man who ran an organization called Volunteers in Medicine. I don't know if any of you have heard of this organization. It actually started off in Hilton Head Island, South Carolina. He was a very distinguished, gentlemanly, elderly Southern man living in Hilton Head, South Carolina, and he realized that many people on the island did not have health insurance. So, and he was a physician, he was a retired physician. So he got together all the retired professionals in Hilton Head and opened a free clinic called Volunteers in Medicine. These clinics have now spread around the country. They are retired physicians, nurses, other healthcare providers who volunteer to provide care for the people in their communities. They are deeply committed, compassionate, good, saintly people who devote their lives to doing this. And I asked this man, what do you think about universal health insurance? What do you think about dealing with this problem? And he was vehemently opposed to the idea of universal health insurance. I thought, how can you be opposed to this idea, given your compassion, your concern? And his feeling was that actually what they did was better, that this expression of individual compassion and generosity, this expression of charity, remember we call the delivery of care by hospitals to poor people in this country charity care, that this act of charity, of human charity, was kinder, was better, created a bond between people that was more valuable than we could ever achieve through universal health insurance. So this reliance on professional compassion actually characterizes the way that we have dealt with the problem of low-income people not being able to afford health care for a long time. We've done it fairly successfully. My colleague Larry Brown, who is a political scientist, so I can use his work to pretend that I'm a political scientist at the moment, argues that this reliance and the success of this reliance on professional compassion is the reason that we have, and this is only a year old, the amazing non-collapsing U.S. healthcare system. If you read back in the literature, back all the way to the 60s, what health policy reformers say, they say the system is about to collapse. We are going to move into one of Uve's two strategies. We're either going to rationally ration care or we're going to have universal coverage. Larry says, no, nothing's going to happen. We're going to keep on keeping on the way we always have because we have built a safety net. We have built a system of professional compassion that actually takes care of the problem just enough that we don't face it in our everyday lives. Now, why might one be skeptical about using professional compassion as the basis for a healthcare system? First of all, it seems to me that it is not responsive to this problem of human dignity that I think is really central to the issue. But it also is deeply dysfunctional in terms of institutional design. And the reason for that is that being uninsured, being a low-income person, or just lacking the means to pay for health care is not a problem that is visited on a very small number of people who are distinctive for a long period of time. Rather, it is a phenomenon that affects a very large percentage of our population. If you take 18 to 24-year-olds, about 60% of them have the experience of being uninsured for at least 1 month over a 4-year period. And even if you take people 55 to 64, 20% of them experience an episode of uninsurance over a 4-year period. This is a very pervasive problem within our system. For these people themselves, this experience of being uninsured and having to rely on professional compassion, I think, is troubling. But for a healthcare reformer, it also creates systematic problems within our institutions. What are those systematic problems? Yesterday, Uwe made the case that one of the big problems with our healthcare system are insurer administrative costs. A large component of insurer administrative costs are associated with the fact that people move in and out of insurance coverage. A large element of what insurers do is sell coverage to people, find people to whom it is profitable to sell coverage, persuade them to buy coverage, to renew their coverage, to continue paying their bills. This is the reason that insurance administrative costs in large firms in the United States are nearly as low as in the Medicare program. But insurance administrative costs in the individual market are astronomical. It's not about the insurance company, it's about the product and the nature of the sale. So having people cycle in and out is a really important component of insurer administrative costs. Second, it's impossible to do provider-side cost containment if you have people cycling into and out of the system and you are relying on professional compassion to keep the place going. Because as we've seen in specific examples in Los Angeles and other places, when you try and cut provider prices, the supply of uncompensated care dries up. Professional compassion is bounded by the fact that doctors and hospitals have to make a living as well. Third, your ability to direct the system from the top, to do quality control, even to do pay for performance and other initiatives is also limited by the fact that you are pushing on a balloon. And you always have the problem that if you push too hard, some other people are going to be knocked out of the system. And finally, if you are a real economist type and you really believe in consumerism in the healthcare system, and forget about the high deductible plans, but consumer choice, consumer motivation, the fact that people are moving in and out of the system and have to fear for whether they can get access to care at all in the future is a real impediment to their ability to search for providers who meet their needs and so forth. So it seems to me that this idea of dignity as the primary problem also links up with institutional design problems in terms of where we have to go with our system. Okay, what is the implication of this value for the institutional design of the healthcare system? I would argue that it has one implication and one implication only, and that is that we need to cover everybody. And that is the only thing that we can actually derive from our value system and from the institutional complexity that I've just described. The organization of the system, if you look across the OECD, matters remarkably little Healthcare economists spend all of our time worrying about things like, should we have a single payer plan or a multiple payer plan? Should we have for-profit hospitals or not-for-profit hospitals? Do we need to do something about our malpractice system or not? Do we want to have a two-tier system or should it be purely egalitarian? Should our doctors be free for service or salaried? Do we want public delivery or private delivery? My view is that none of this, to the best of my understanding, makes enough difference to actually be observable in a regression coefficient. So let me show you the evidence on this. And I have Jill sitting here looking very skeptical. This is data. Yesterday, Uwe talked about the declining efficiency of the healthcare system, and I want to show you a set of slides that I find really, really disturbing. But this is the countries in the OECD and male life expectancy at age 40 in 1976. Now, I put up a bunch of countries here for whom I have consistent data over time, but the striking feature of these countries is how diverse their healthcare systems are. The Swiss healthcare system and the Swedish healthcare system could hardly be more different. The Swiss system relying heavily on private insurance, the Swedish system being sort of the archetypal single-payer kind of model. There's the UK in there somewhere. I think maybe I don't have the UK in this data. Canada's there, the single-payer system, and there's the Dutch, which at that point were letting 60% of the people out of their system into private insurance. There is tremendous diversity among all those OECD countries, and there is the US amongst them all. Now, I look here at male life expectancy at 40. Why male life expectancy at 40? That is the group who have experienced the biggest increases in life expectancy in the United States. So this is a group that's actually done very well. And it's also good to look at males at 40 because by then, all the risk factors that we worry about are over. 40-year-old males go home at night and watch television. They don't drive fast cars anymore. None of the social pathologies affect them. Drugs are over, homicide is done. They just watch television. So let's see what happens to them. Okay, so there is real improvement in male life expectancy at 40 in the United States and in these other countries. You can see, oh, by the way, this is 1976. We actually spent a little more than everybody else, just a little bit more. We spent about twice as much as Canada. We always spend twice as much as Canada. It's an empirical regularity. It's a rule. And our life expectancy numbers were sort of in the middle of the pack, kind of at the lower middle of the pack, would you say? Lower third of the pack. All right, so this is 1976. Here's 1986. Again, you see all of the countries arrayed with their very diverse healthcare systems. I just really want to emphasize, Switzerland and the UK, for a European to imagine that these systems have anything to do with each other would be absurd. It would be like saying that Mississippi and Manhattan are the same thing. It would make no sense at all. Again, we spend about twice as much as Canada. We're actually doing a little better in 1986. Life expectancy, you can see how everybody has moved over to the right here. We're all doing better. And it's spreading out a little bit. You actually see kind of an encouraging upward slope here. Spending more seems to buy you something. That's only true in 1986. Here's 1996. Again, Canada, US spends twice as much as Canada. Everybody is doing better. But notice how we are sliding backwards a little bit on the life expectancy numbers compared to the other countries, and our costs are really escalating, and also how close the rest of the pack is to one another. How little diversity there is among all of those other countries when you have us in the picture. So this is 1996. So here, get ready. This is 2006. Okay, not only are our costs just phenomenally bigger than everybody else's, but we have actually slid backwards on life expectancy so that we are now substantially behind the rest of the pack. This is true even if you look only at white males. It is also true if you look at people at age 65. It is also true if you look at women. We are doing badly all around in our healthcare system. And what do I say in terms of what we can say about system design beyond the fact that the United States is a disaster area? I would argue we can say nothing. Give me a dartboard and throw the dart at any one of these systems and I would take it in preference to ours. And I would have a very hard time arguing that any one of them was better than any other one. So overall, I think what this story tells us, what is the big difference between the United States and these systems? It is not fee-for-service compensation of doctors. It is not the existence of private insurance companies. It is not the existence of for-profit providers. It is none of that. The main difference between the United States and all these other countries is that they have universal coverage and we do not. So I think if you're looking for Occam's razor, what is the simplest explanation for this bad performance, I think that is what you have to conclude that it is. So how do we move forward? Are values key to moving forward? Yes, because values tell us where we're going. But I would say no if you actually look at the politics of this. Does it really matter? Do we really have to have a debate about values? Do we have to educate Americans that professional compassion is not a dignified way to run your healthcare system? I don't think so. And why not? This is the timeline of when different countries in the world adopted universal health insurance. Germany was the first in 1880. It wasn't exactly universal, but they moved then. Canada actually didn't get all the way there. The legislation was passed in 1966. The last province didn't adopt till 1971. And Denmark, actually, those Danes, yesterday we were talking about them, they didn't actually get to universal till later than that. So what was going on? Is this an outpouring of values that can explain what happened in these countries? Well, that's Bismarck. Back in 1880, it is hard to believe that Bismarck passed universal health insurance or universal insurance in Germany at that time because of a feeling of social solidarity. On the contrary, he passed it because it was politically necessary in order to keep from there being a revolution of the working class. And conversely, is my picture going to work? Yeah. That's Lester Pearson, right? Who passed universal health insurance in Canada, also not famous as a sort of ideologically important person or anything. He did it because there was an NDP, a socialist minority government. He had to keep the government in power, and he passed universal health insurance. Now, was there a big outpouring of social solidarity in Canada in 1966? No more so than in the United States. Medicare passed at exactly the same time. Nothing really very different between the two countries. There is a huge difference now. And I think that is actually the insight that Newt Gingrich had, which is not that values lead to coverage, but that coverage leads to values. If you give people universal health insurance, they will come to feel social solidarity around health care. It is not social solidarity around health that gets them to universal health insurance, but universal health insurance that gets them to feel social solidarity around health. The fact that politics matters more than values, I think is particularly true in the United States, because as I read it, the United States political system is designed to be responsive to interests more than to ideologies. It is not designed to be some place where you can walk in with a broad sweeping agenda and be transformative. And I think it is striking that Medicare Part D, the largest expansion in health insurance costs, certainly at the federal level that we've seen since the mid-60s, happened with a Republican president and a Republican Congress, an ideologically Republican and conservative group. That affected the design of the program, but it did not affect whether it got passed or not. Bill Clinton was not able to get it done, and George Bush was. And that suggests to me that politics trumps ideology here. Now, politics is really difficult, and again, for the point that Uwe raised yesterday, because health insurance reform is a problem for the demand side, but it's a much bigger problem on the supply side. Uninsured people are not going to march on Washington demanding universal coverage. They're not going to do it for two reasons. First of all, because only a small fraction of them will actually suffer for being uninsured in a given year. 50% of people incur 3% of healthcare costs. For half the uninsured, they will have no contact with a doctor and they won't mind. So there's no reason for them to go marching to Washington. For the others, for most of the others, uninsurance is not the only problem in their lives. These are low-income people. They have lots of things going on, lots of political concerns and concerns in their own everyday lives. They are not going to be advocates for health care. Rather, stakeholders in the system, and that means suppliers of healthcare services, are going to be the main stakeholders in this decision process, which is going to make this very messy and very difficult, particularly because everybody at this point, there is almost universal agreement that we need to expand coverage in this country. The insurance companies are on board, the doctors are on board, the hospitals are on board. Everybody agrees that we need to do this, but everybody has their own way that they would like to go about it, and everyone's second favorite option is the status quo. So how we move forward is going to be much more difficult, I think, than just getting a values-based agreement about the fact that we need to do it. And I just want to point out the nature of political power of the suppliers in the United States is probably, and I want Mark to comment on this, is actually probably much more salient than in any other country because of the nature of American politics. So I was looking at what are the factors that really make you politically potent. One of them is having widely geographically dispersed membership that is of significant importance in every congressional district. We call those short-term general hospitals. Every congressman has one, and they are very important employers, and they're going to be very important lobbyists, let alone doctors. factors. And if you actually look even now at the top lobbying industries, I had another slide that looked at where defense is in this. Defense is way trumped by the healthcare sector in terms of lobbying already. So we have a political system that is very responsive to the needs of providers, and we are going to have to come out of this, debate trying to figure out how to square that circle. So how can we do it? Well, does everyone recognize both of these pictures? I already told you who the first one is. The one on the left, they both had the same title. The one on the left was Bismarck, and the one on the right is Angela Merkel, who was Chancellor of Germany in 2007. Why are these dates important? 1883 is when the German health insurance system began. It did not begin as a universal system. It did not begin with risk-adjusted sickness funds and with lots and lots of disease management and other good stuff. But they keep revising their system every 2 or 3 years, doing radical reformations, the most recent being in 2007. So this is over 100 years. We should not imagine that we are going to build the perfect healthcare system from the beginning in the United States. And I think I'm referring to Germany and Canada because I know the experience is best, and also in homage to Uwe. But do you recognize who these three people are? Any of them? You're right across the border here. Tommy Douglas on the far left, as he belongs. All right. The person in the middle is Jason Robarts, who was a Premier of Ontario in 1969, when Ontario became the last province to sign on to Canadian Medicare. So Tommy Douglas was the person who started the national health insurance in Canada. He did it in 1946 in Saskatchewan. All right? He started it in Saskatchewan. It took until 1969 before the last province signed on, and that was Ontario. Robarts, interestingly, was a libertarian, conservative ideologue, a free market individualist. And why did he sign on? He basically had a Mitt Romney situation. He was going to lose a lot of federal money if he didn't bring universal health insurance to Ontario. It was not an ideologically driven decision. It was a pragmatic one. And the person on the right, although he doesn't really belong on the right, is Jean Chrétien, who was Prime Minister of Canada at the time that they did their most recent significant revision of the Canada Health Act. So again, we should not go into this thinking that we have to solve universal health insurance in the United States once and for all in one dramatic sweep. Instead, I think that what we want to do is recognize the political realities and think about doing institution building that is a little more incremental. And so I have this idea that I'm just going to throw out because I get all these people to talk to, and why not? Which is that one of the things that is on the political agenda that Congress has to deal with very soon is the SCHIP program. I don't know whether you're all familiar with that program. It's a very relatively small federal program that provides states with money to provide coverage to low middle income children, children with incomes at the moment under 200% of the poverty line. Last year, Congress wanted to extend the upper income limit on that program to 300, 400% of the poverty line. Bush vetoed that legislation. They need to pass it again to reauthorize it, or the SCHIP programs will all fall apart. I've suggested that rather than simply reauthorizing the program, they actually go ahead and pull a Mitt Romney on every state governor and say, listen, you can have the SCHIP money, or if you build a plan for universal coverage for kids, we will give you a lot of additional money. So the money's on the table. Build your plan for universal coverage of kids. Why kids? Because you age into Medicare, but you would age out of universal coverage for kids. So I think in that sense it is a more valuable incremental step. Also because the institutions needed to build universal coverage for kids through the SCHIP program would be the same ones needed to expand health insurance broadly to the entire population. Insurance connectors, mandates, and so on would be the elements of that kind of reform, and I think that's the direction that we're likely to go.
I really liked your decade-by-decade international comparison, but one thing that has to be thought of is income inequality in those different countries over time. And so I guess I would be reluctant to think, Sherry, that if we just went to universal coverage, the United States bubble, the little dot, would approach that group. So, I just think that the income inequality issues have to be brought into play.
It's certainly true that income inequality matters, except that if you look among the European countries, again, if you just take the U.S. out of the picture, there is a lot of variability in income inequality within Europe, and it doesn't show up in that picture. So I think it is not, pardon?
The United States is still the outlier in terms of income inequality relative to all.
Absolutely. It's not it's not the only thing, but income inequality doesn't fit that regression line any better than much else within Europe. Now, I don't think that.
Well,
universal health insurance.
Disputing your argument
Right.
that within that cluster, the type of system
Doesn't matter.
better than the other, or that within that cluster, income inequality. I was talking about the U.S.
Right, no, and I also agree with you that income inequality and the pathologies associated with it have effects on health and life expectancy that are certainly not the province of the healthcare system. But it does also seem to me that many of the kinds of reforms of the healthcare system that all of us would like to see, the focus on quality, more sensible payment methods, all kinds of other innovations that we would like to see, are really impossible to do unless we have everybody covered one way or another. So it seems, I don't think that we move from there to the Europeans in 1 year or even a decade. But I think that if we concentrate on something else besides universal coverage first, we'll never get there. Yeah. Hi.
I think it's a good place to start to look at versus international costs and health status. I think it's instructive as well to look at the variation of health status and costs within the U.S. And there's large portions of the U.S. mainly those states for whom their cost structure and their health status have been compared very favorably with any of those other countries. I don't think that universal health coverage is what's different between those states that do well and those that do poorly in the U.S. And surely there must be something about organizational structure in the way we pay for health care.
Well, so I took the slide out here, but I often tell people that we don't actually have to transform our country into some socialist dreamland. We just have to all move to Minnesota, and we'd solve all of our problems. And I think so I'm completely with you on this point. It is true that health insurance coverage rates are actually correlated with those bad outcomes too. So it's all part of one story. Minnesota not only has good health care and cheap health care, but lots of people covered. So it isn't those, and the red states don't look very good on any of those dimensions. I don't want to suggest that health insurance coverage is the reason Minnesota looks different from Texas. That's not the only reason. But the Medicare program pays providers in the same way in all those places. The institutional design is hard. We have for-profit and not-for-profit in all those places. There are certainly other things that matter a great deal, but the question is, how does policy affect them? And I don't see that. Yeah, hi.
The economic crisis today is going to slow down any kind of reform in the medical field?
I think it might be orthogonal. I think there are sort of three different things going on. On the one hand, the Congress, or four different things. Congress is going to be spending a lot of money on other things, and maybe they're going to get nervous about spending more money on healthcare. On the flip side, maybe somebody can argue that healthcare is a stimulus, and that would be good. I don't know how credible that argument is, but let's just leave it on the table to counterbalance the other one. On the other hand, more people will be losing their jobs and uninsurance rates are going to go up. But as Health Affairs website says yesterday, healthcare cost growth is going to go down, and that will keep a lot more people in the market for a while. So I don't know that it's going to matter in the end. Maybe the big thing that will change is more a values idea, that people's ideologies will be less, people will be less ideologically opposed to government having something to do in the system. That's kind of the hope, but I don't know how long that will take. Yeah.
Thank you for your nice speech. I like the central theme that to win the hearts and minds for universal health care, we need to have the idea that this is something that gives people security. Wars are fought over insecurity. Everyone has a motivation on things that they do for their family or in their community, where there's squabbles and whatnot, is because people are insecure. You're insecure about losing your job. You're insecure about being laid off or whatever. But I think what we need to do is emphasize more of what you're doing. In order to get people off this scary, oh, this is socialized medicine theme, is to present what you're presenting today and get that message out there. That we always support, whether it's the arts or the school. If you don't have any children in your family, you still feel good about supporting the local school district because you were an elementary school student at one point. Even if you don't have children, you pay a tax for them. we certainly, when we spend almost $1 trillion for this Iraq war, imagine if we had used that money as a reserve for a healthcare system. We'd have a big trust fund already.
So, I agree that appealing to people's concerns about how they will be treated in the system is an important dimension here. And I think actually it was one that was used against reform the last time around, trying to build the idea that somehow healthcare reform would add to people's insecurity about their healthcare coverage. So I think that is definitely a direction to go forward.
Do you have any thought about prison healthcare? I'm involved in looking at that. It seems abysmal throughout the country and fairly costly as well.
So I actually have not looked a lot at prison healthcare, and I'm nervous about overstepping my bounds. I do think, actually, that from a sort of ideological point of view, the very fact that we do feel that we have to give prisoners health care speaks to the idea and that we do think that there are values associated with having this kind of service, even for people whom we have put outside of our society. It doesn't surprise, I mean, it is a very poorly run system. It's a very expensive system. There are lots of things wrong with it. We could do it better. I don't know what else to say. Thank you.